afternoon, everyone, and welcome to the Recovery Science Echo brought to you by Peer Recovery Innovation Network and Center for Substance Use Training and Telementoring CSTAT. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. We encourage everyone to join by video for the discussion portion, especially in the latter part of the session. That said, regardless of how you have shown up today, we are just as happy you're here to learn alongside us. We are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information you put into the chat will not appear in the recording. Please stay muted unless you're speaking, and we do encourage you to speak. If you join by computer, your mute button is in the bottom left of your Zoom controls. If you are on the phone, just press *6 to unmute. You can also use the emotions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. There are a lot of us in the space, so please keep your comments brief to allow others a chance to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, or anything that can easily identify an individual. Towards the end of the session, our wonderful IT support, Angela, will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education credits. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on recovery coaches and will be presented by Dr. David Eddy. Following that, we will discuss a case presented by Kristen Gallegos. We will start with introductions, followed by didactics, announcements, a case presentation with open discussion. Thank you all again for joining us today. These sessions are what we make of them, so we encourage you all to share your questions, insights, and perspectives in today's conversation. And with that, we will do some introductions. Robert.
Morning and afternoon, everyone, depending on where you're joining from. I'm Robert Ashford, one of the hub members and co-investigator on the R24 Peer Recovery Innovation Network at UT and Be Well that sponsors this hub. Thanks for being here.
Thank you so much for joining us. Sierra.
Hi, I'm Sierra Castedo de Martel. I'm a postdoctoral fellow with Chestnut Health Systems Lighthouse Institute and a person in long-term recovery, and I am one of the hub members.
Thank you so much for joining us today. Emily.
Hi, I'm Emily Hennessy. I'm an associate director at the Recovery Research Institute and also one of the hub members.
Thank you so much. David Eddy.
Hey everybody, I'm David. I'm a clinical psychologist at Massachusetts General Hospital and Harvard Medical School. I'm also the Associate Director of Translational Clinical Science at Recovery Science at the Recovery Research Institute with Emily.
Thank you so much for joining us today. Kristen?
Hi everyone, I'm Kirsten. I am the project coordinator for PRIN and I work with Dr. Ashford.
Thank you so much, Kirsten. Andrea Hebler?
Hello everyone, my name is Andrea Hebler and I'm a program coordinator here at the Center for Substance Use Training and Telementoring, CSTAT. Welcome everyone.
Thank you. And with that, we will move on to our didactics for today. Dr. Eddy, you can take it away whenever you're ready.
Right. I think you have my slides already. No, we took them down. Okay, just give me 1 second. All right, how's that looking to you guys?
Looks great, thank you.
Okay, fantastic. So it's a pleasure to be here today. As I mentioned in my introduction, I'm a researcher and a psychologist at Massachusetts General Hospital, and I've been doing a lot of work lately on recovery coaching. Principally, that's focused on a recent scoping review of the scientific literature on peer recovery support services, principally recovery coaching. And I wanted to share with you today some of what we found. Those data have not been published yet. We've actually just submitted those for publication. So that'll be, appearing in a journal near you soon, hopefully. But I wanted to give you a bit of a sneak preview of what we found. But first up, let me go through my disclosures. I'm the co-founder and a partner in Peer Recovery Consultants, and we provide individual and family recovery coaching to folks in the community, and also consultation to industry and healthcare systems. I'm on the scientific advisory board of a company called Vivi Health, which is a digital therapeutic for substance use disorder, and I'm also on the scientific advisory board and a stockholder in Innerworld, which is a VR virtual reality platform for mental health recovery. So the learning objectives today, hopefully you'll come away from this knowing a little more about what recovery coaches do. And I recognize as well, many people on this call, on this Zoom chat today are going to, work in this field already and are going to have a deep knowledge of this space. And, so hopefully, sharing some data that'll be helpful to you all. And some of you, maybe know less about recovery coaching, and hopefully some of my introductory remarks will be helpful to you. So, I will share a little bit about where recovery coaches are being utilized currently in the field. And also, hopefully you can walk away with some impressions about the efficacy or effectiveness of recovery coaches based on the existing literature. So what are recovery coaches? Well, essentially, the peer-driven mentoring, education, and support services delivered by people with lived experience of addiction and addiction recovery. And generally speaking, their goal is to link people to existing forms of formal treatment and mutual help programs, and potentially also to supplement treatments. Now, that's, a gross oversimplification. Recovery coaches do so much more, and I'll get into that. But you can think heuristically about these are the kinds of things recovery coaches are doing. So SAMHSA came out with a definition as well. They say that a peer helping recovery coaches can be summarized as a peer helping peer service alliance, in which a peer leader in stable recovery provides social support services to a peer who's seeking help in establishing or maintaining their recovery. So it's really important to also know what recovery coaches are not, because I think there's some confusion. For those of us in the field, those who work with recovery coaches, I think we have a pretty good sense of what recovery coaches do and don't do. And I think for people outside the field, maybe family members of people with substance use disorder, or even people entering treatment who are fairly treatment naive, they might not have a clear understanding of what recovery coaches do, and they might have some confusion about roles. So it's important to know recovery coaches are not sponsors, so they're not an AA or NA sponsor. And in theory, they're not aligned with any one therapeutic approach either. So there are no CBT-oriented recovery coaches. Now, some recovery coaches may know more about one form of treatment modality or another, but they don't have an allegiance. They don't diagnose and they don't provide psychotherapy or treatment, though they can provide really important psychological and instrumental support to people, though we wouldn't call this psychotherapy. We wouldn't call it treatment. So where are recovery coaches being utilized? Well, really across the spectrum of substance use disorder treatment and care. So at Mass General Hospital, where I work, we've been utilizing recovery coaches really at all levels of care, inpatient and outpatient, and in the ED for years now. We have, a sizable roster, I think of about 20 recovery coaches at any given time, and they just do phenomenal work in the emergency department. When people are coming through presenting with substance use related medical problems, maybe an opioid poisoning or a broken bone as a result of a fall while intoxicated. Every person coming through the ED with a substance use related medical or psychiatric problem gets a visit from one of our recovery coaches who's going to talk to them in a really non-confronting way, using a lot of motivational interviewing strategies about the treatment options that might be available to them if they wanted them. But we also have recovery coaches working in inpatient units and in our addiction consult team, which is essentially a team of psychologists, psychiatrists, and recovery coaches who go around in inpatient units and visit with people who have substance use related presentations to talk to them about treatment. Also, we use them in our outpatient clinics, and I'll talk to speak to outpatient clinics in a second. They do really important work there as well. Recovery coaches are often utilized in detox units, in medically managed withdrawal units. So the goal here is often for a peer recovery support specialist to help connect people to treatment. Often people going through medically managed withdrawal have some ambivalence about whether they want to continue with treatment, whether they want to engage in maybe residential care after being discharged from a withdrawal unit. And recovery coaches can do amazing work in helping shore up motivation and to continue with care, and also to make linkages to those treatment options. And we also know recovery coaches can work in halfway houses, recovery community centers, and I mentioned before, importantly, they're doing great work in outpatient clinics across the country and perhaps around the world. At Mass General and in our outpatient clinics, every substance use disorder related clinic has a designated recovery coach who works closely with the psychologists, psychiatrists, and clinical social workers on the team. And really, they're an integral part of the work we do. And importantly, recovery coaches can do a lot of things that we can't as licensed professionals do. They can really literally and figuratively meet patients where they're at in the community for a coffee, or go with them to a meeting if they're feeling ambivalent or uncomfortable attending a mutual help meeting, things that would be inappropriate for say a licensed psychologist to do. So we think recovery coaches can cover some really important clinical care gaps. So what does the certification landscape look like? Well, it's a real hodgepodge right now. This slide's a little bit old. I want to say it's about 4 years old. But essentially, certification varies by state. But most states do have some kind of certification protocol in place. Now, that might be privately managed. The state might outsource that to a private organization. It might be publicly managed by the state. Importantly as well, recovery coaches receive a lot of different job titles, depending on where you are in the country, or even within organizations. Recovery coaches may have different titles. And I think this is part of the reason why there's some confusion around what recovery coaches do or don't do. And in most states, high school diploma is required, or a GED, or at least passing some kind of exam. And interestingly, 13 states, at least at the time this slide was put together, required that recovery coaches actually had lived experience of addiction recovery. And now the hours and training and work experience required to be a recovery coach varies greatly. Just a note here, this slide was made by UMass, so there's emphasis on Massachusetts here, but they're just noting Massachusetts requirements are generally above average, but there's a real range from state to state. So there are some organizations that do provide certification, and probably most of you have heard of NADAC, which is a really well-regarded certification organization. In Massachusetts, we have a CARC, the CARC certification, and CCAR in Connecticut is pretty well known as well. And I believe some states have adopted the CCAR model for certification because it's kind of thought of as a gold standard, or at least it was last time I looked. I just wanted to include this slide here. This connects to a SAMHSA report with the state-by-state directory of peer recovery coaching, training and certification programs. I just thought this would be a good resource for folks. And I presume we'll share these slides afterwards, and hopefully that link will work. If it doesn't, you can Google this, and it's a publicly available document. You'll have no problem finding it. All right, so let's get into the review we did. So we identified 39 studies in our scoping review. First was published in 1998, and this sort of cuts out at the end of 2023, which is when we sort of wrapped up this work and essentially went to print. But we had 9 randomized controlled trials, 12 comparative trials where there was some kind of control or comparison group, and 18 single group studies. And I've got some stats in here if you want to look at those later. But let's talk about the studies and what they looked at. So not surprisingly, the studies we identified, they covered a wide range of peer recovery support services. This has included recovery coaching. Some assessed a peer education intervention. Some were just providing skills training. There was great variability in treatment intensity. So some of these studies were investigating the efficacy of a single session intervention, say to help people connect with or engage with formal treatment from the emergency department. But other studies provided support and followed people for 6 to 12 months. There was a wide range of populations studied as well. All these studies had an emphasis on substance use disorder treatment and care. That was one of the inclusion criteria for our review. But many of these studies included people with comorbidities. Some looked at folks who were recently incarcerated, for example. And as well, there were a wide range of research settings represented. So there were studies conducted in inpatient medically managed withdrawal units, residential and outpatient treatment programs. There were several studies conducted in primary care settings where recovery coaches were working with physicians to try and improve substance use disorder outcomes. And there were also harm reduction programs represented. So this made distillation of this literature challenging. We did our best. And what we did is we ended up discussing the research by primary outcomes. And that's the way I've organized this talk. So first, let's talk about substance use outcomes. Of the 39 studies we looked at, or 39 papers, 13 included some kind of substance use outcome. Now, you might say, well, that's odd. You would think maybe more studies would have included some kind of substance use outcome in their measures. Maybe, maybe not. I mean, the reality is a lot of what recovery coaches do and do really well is not really about managing substance use. It's about helping people connect with services and engage with those services and accrue resources that can support recovery, like recovery capital. So maybe at face value, this is a bit surprising, but I don't know. I think perhaps it's okay. And generally, though, the results were positive. The effect sizes are modest, but a lot of these interventions were brief, minimal, and yet still produced positive outcomes in terms of reductions in substance use. We saw studies demonstrating reductions in alcohol use, cocaine use, and in a lot of studies looked at multi-substance. They were sort of agnostic to substance. They just wanted to see were people reducing in substance use regardless of what their primary substance was. I just put a little note in here, though, about potential for reporting bias. One reason only half the studies reported substance use outcomes could be because some studies didn't find positive results in substance use outcomes, and they might have just failed to report those findings. Now, we don't have any evidence to suggest that's the case, but it just there's something just to bear in mind. It's possible. It does sometimes happen. Only 3 studies looked at substance use disorder severity. Generally, the findings here were, trends and positive. So Bernstein et al. Saw reduced addiction severity in individuals receiving like a brief intervention in a primary care setting, and I believe that was like a single session intervention. So you would think even a small reduction in addiction severity or substance use disorder severity presentation from a single session intervention, and that's still valuable. And Boyd and colleagues and Crothers et al. Also saw reductions in physical, interpersonal, and intrapersonal consequences and increased likelihood of no health related behavioral and social consequences of drug use over a 6-month follow-up in the latter study there. So some promising outcomes here, but really it's a bit soon to know, just based on the extant literature, what kind of effect on substance use disorder severity we can expect from peer-based interventions. Now, treatment linkage and engagement, this is really where we saw a lot of action. 17 papers, 5 of them gold standard randomized controlled trials. reported on linkage to treatment, treatment engagement, and medical readmission. And generally, I mean, fairly overwhelmingly, the results were positive. And it really does suggest that if peer recovery support specialists do one thing and one thing well, it's connecting people to treatment and helping them stay engaged in treatment. And this makes sense because really recovery coaches can plug a lot of care gaps. And also, I think there's a relatability of recovery coaches because they're peers, they're people with lived experience, they've walked the walk, they've been in the patient's shoes. And I think they're more relatable and more trustworthy ultimately than licensed clinicians. And remember as well, a lot of these studies were conducted in, or some of them were conducted in emergency departments where, if you're somebody with substance use disorder, the emergency department is not always a fun place to go, right? There's tons of stigma and judgment and blame. And, potentially recovery coaches might be able to offset or mitigate some of the detrimental effects of that stigma, I think, and maybe make more likely for people to accept referrals to formal treatment. So really exciting. Only 6 papers reported on recovery capital. So just for those who don't know, a lot of you will be familiar with this term, but recovery capital is really just a broad umbrella term that covers all the resources available to an individual that could support them initiating and sustaining addiction recovery. So this can be things like employment, stable housing, access to health insurance and healthcare, but it could also include like social supports as well. So it's a broad umbrella. This is something we think like, a priori that recovery coaches might be particularly good at because they often have a really good sense of the kinds of resources in the community and that therefore would have the potential to help people connect to those resources. Only 6 papers, though, reported recovery capital or related outcomes. I think one actually used a recovery capital measure. Most, though, were reporting on things like housing and employment. And generally, the results were positive. And there's a study here by Rob Ashford, who I know is on the call today, and he'll probably be able to share some thoughts. Not so much work done on positive and negative affect and these kinds of outcomes. And, maybe that makes sense. These peer-based interventions weren't necessarily looking to address positive and negative affect, but, the preliminary research so far suggests there's some potential to reduce negative affect. There's only been, I don't think, but none on positive affect. That's right. There was one study by O'Connell et al., and they actually saw increases in negative affect associated with working with recovery coaches. But the authors posited in that study, potentially that was a function of the recovery coaches challenging the participants to sort of step up and own their own recovery in ways that may have initially increased negative affect. But I think more research is needed because, sometimes being challenged in that way, ultimately is going to produce longer term benefits. So you might see some initial increases in negative affect, but there might be long term benefits associated with being challenged in that way. So it's something we should be looking at in future studies for sure. Just two papers looked at quality of life. Boisfert and colleagues found no change in quality of life over like a 9-month study period. And Ray and colleagues saw modest improvements, but their control group also showed similar improvements. So both groups were improving. So maybe the improvements were really more just a function of time. So that's it. That's really where we're at. The takeaways here, there really is strong evidence to support the efficacy of peer recovery support services for treatment linkage and engagement. And I think the effects for, in terms of substance use outcomes are also maybe equally as promising. There's some preliminary research suggesting that recovery coaches can help in their accrual of recovery resources, i.e. recovery capital. But we really need more work there. And I think it's a call to arms for researchers doing work in this space, but I think in substance use disorder research more broadly, we've thankfully as a field moved away from our hyper focus on substance use outcomes and abstinence, and we're recognizing that we really need to be measuring recovery capital as well if we're doing recovery research, because that's ultimately, these are the stuff that are going to help people initiate and sustain recovery more than anything else. And I think more work is really needed to see how peer recovery support services can influence quality of life. And it's notable as well, when we're talking about recovery capital and quality of life, it can take time to accrue recovery capital and quality of life, right, in recovery. And most of these studies at most follow folks for 12 months. And I think, future research, we really need to be following people for longer. It might be that, we may not be seeing much benefit on these measures in the first month, but first 6 to 12 months, but that doesn't mean there aren't benefits there. And it's also going to be interesting to see, I think in future research, how these outcomes interact with, say, substance use outcomes in terms of, helping people manage their substance use more effectively, and also just ultimately build lives worth living. So I put the references in here if you all want to check out the papers we cite in this review. And just a quick shout out for the Recovery Research Institute and the work we do. We have a great website full of resources. We have a dictionary of addiction-related terms. And importantly as well, we put out a monthly bulletin. It's free. We summarize 8 current addiction recovery studies from the clinical science literature in a sort of Reader's Digest, easy to read, quick to read format that's really accessible to researchers, clinicians, but also lay people and people working in the community who maybe you don't have access to these peer review papers because they're not affiliated with the library system, or don't have time to read these papers. It's a great resource. So look us up at recoveryanswers.org and you can sign up for the bulletin there. So with that, I'll end there. We'll take some questions. Thanks so much.
Thank you so much, Eddie, for this wonderful presentation. I'll open up the floor for any questions or comments from our learning community here. Yes, Lindsay.
I'm just curious if you've come across any research on if there's any research around how peers are doing in the field, if they have a clinician as a supervisor as opposed to somebody who's been a peer as a supervisor. And also if there's any research around how certification impacts the provision of services.
Yeah, they're great questions, and I think it's a no and a no. At least in what I came across in my read of the literature. Now, your latter question, that might be a separate research question that might not have popped in our searches, but the search criteria we were using, I really felt like we were trying to capture any papers that were published really ever on the topic of peer recovery support services. So our search criteria were very broad, and nothing came out. But that's a great question. I mean, it's an empirical question, something you could assess. And I could see there being sort of, pros and cons associated with having like a licensed clinical supervisor versus a peer. I think there'd be benefits of both, and maybe some cons of both as well. I mean, I think peers understand peer work better than clinicians, much better. And I think there's some, I know, from talking to a lot of peer providers, getting good supervision can be challenging because clinicians often bring their own biases and they don't always understand, the role and the special things peers can do, but also the limitations of what they can do. We all have limitations in our roles. And so I can see there being benefits both ways. But, if anybody on the call has any data on that or any knowledge, I mean, I'd love to hear about it.
So I don't have data, but I've got personal experience. I mean, because
What's your experience been?
It was 9-day. I worked at a place where originally it was a LMHA, local mental health authority, where I worked under a clinician as a peer, and it was very difficult because I was failing all of my reviews, saying I was sharing too much and I was in the community too much, and just a lack of understanding of what my role was,
Yeah.
as opposed to moving into the community center where I was recovery community center, where my supervisor and everybody was a peer and everybody understood what we were doing, and they were also more reactive. They were better at, you know, reacting to certain situations that we would find ourselves in and things like that.
Yeah, I'm not surprised, actually. Yeah, and I'm sure a lot of people on this call could probably share similar experiences. But that is something, you know, I think we should be studying to understand better, so we can have guidelines around this stuff. Yeah, thanks.
Thank you.
There's definitely recognition that there's a need for more research on the workforce itself. So I have a review that's partially workforce focused that's in press right now. And then there's a protocol for one that is much more workforce focused, that's in progress. So hopefully that'll be out, you know, within the next year.
Oh, fantastic.
And looking, you know, at some of those questions, I'm trying to remember specifically if the supervisor question came up, but I do think there's at least some data on what kinds of supervision is happening in the field currently. I don't know that there's that they're connected to any associations with outcomes for the peer workforce themselves, though.
Is that in press article online yet, or is it yet?
It's not yet, but
Okay, I
as
was
soon
going
as
to
it
say
is, I'm
put the
happy
link
to
in
share.
there. We'd love to see it, but
Yeah, it's on it'll be coming out in the Substance Use and Addiction journal, so Immersive's journal.
like,
I'm happy to share that when it's out.
wow, thanks. Yeah.
Thank you so much. And thank you again, Dr. Eddie, for that wonderful presentation. Please keep the questions coming in the chat, and I'm sure Dr. Eddie would continue to respond to them. And in the meanwhile, in the interest of time, we will move on to the next part of our session. Angela, if you could please bring up the announcements from CSTAT. Thank you so much. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via a team of experts. To request technical assistance, please complete an online form using this link, and we will be dropping this link in the chat. Next slide. Do you have a research or evaluation related work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present a research or evaluation related work in progress and receive feedback from our community of experts. There is no need to prepare a formal presentation. We will provide you a form to fill out to assist with your presentation. Please email us at cstat@uthesca.edu. Next slide. To say claim your CME credit, you must text by midnight tonight. Please text attend 1009-7863 to 844-502-1338 to record your attendance. Next slide. Join us for the next Texas session. Trojan Horse Technologies, how surveillance impacts treatment on the front lines of the opioid crisis. This will be on Tuesday, October 8th from 11 a.m. to 12 noon. To register, please use the link. We will be dropping this link as well. Next slide, please. And join us for our next Recovery Science Echo session. This will be on Wednesday, October 16th at 12 noon Central. And with that, we will move on to our case for today. Kristen, if you could go ahead and please share. And Angela, if you could please bring up the website. Thank you so much.
Okay. Hi, everyone. I'm Kirsten. I'm the project coordinator for the Peer Recovery Innovation Network, which was created to help expand the field of recovery science. And today I'm here to talk about one of the ways that we're doing that, which is called an accelerator program. And it's a pilot funding mechanism that we are currently taking applications for. And so I'll be going through our website today that has a lot of the information on what we're doing, why we're doing it. But I did want to take the opportunity to share with you all and just go through it. And if you have any questions, please feel free to put it in the chat or raise your hand, and I'd be happy to answer to the best of my ability. But if we can go down a little bit. Cool. Okay, so the innovation or PRIN is pleased to announce the funding opportunity. And what we're doing here is we're going to talk a little bit about the funding mechanism, and you'll see the bullet points down here that have areas of research that are encouraged but not required. So if you have something in mind that isn't within one of these bullet points, please feel free to still apply. That doesn't mean that you're not eligible. These are just some that we're encouraging. So we want to accelerate the transition from discoveries to active and effective peer and community-based recovery support programs. And so that means is we're wanting just to promote the research so that we can get it out and make sure that what is being researched is going to impact the field. So one of the things that I would love today is if I can get some insight on what people would like to see come up from these funding, from the pilot studies, what you're interested in. I would love to hear that. But some of the areas of research that are encouraged are the role of social determinants of health. You'll see some that are about well-being of the peer support workforce, standardized data collection. And a lot of these are coming from a previous survey that we had. We were asking people in the community to rank what they believe are the most pressing issues in the field. So we want to abide by that and make sure that we're listening to what people in the field say that they want and the research that they need. So some of these are here and they're strongly encouraged. But on the right side, you'll see the contact information for our project manager. Please feel free to contact us either through her email or the print email, which is also on the website. We'd be happy to answer any questions you have. Please feel free for any question at all. You'll also see the area that says need assistance. We have some templates that you can use to apply. We're trying to make it as low barrier as possible. So these templates are built out to help you with your application. But again, those aren't required either. It's just an assistance. And so the applications themselves have to be submitted through SurveyMonkey Apply, and I can put that link in the chat as well. The application is currently open and it is going to run until October 31st at midnight. So we would love for you to submit your applications. And if you go down a little bit more, thank you. So eligibility, we really want to make sure that all project teams include people with lived and living experience in an intentional way and more than just advisory capacity. And so we did want to mention that community partners are absolutely welcome to apply. It does not have to be tied through an institution. We want you to feel like this is something you are eligible to apply for. We also want to encourage Black, Indigenous, and other people of color to apply as well. We really want to make sure that those voices are heard too. Funding is, let's see, funding for internal applicants is up to $36,000 per award for direct costs. And then external applicants, so entities other than UT Health San Antonio, are up to $55,800 per award. And so what we're expecting is that we will fund 3 projects for up to 1 year. And like I mentioned earlier, we have the deadline as October 31st at 11:59 p.m. and those will be submitted through SurveyMonkey. And I saw some stuff in the chat, and it's not limited to just Texas. So please feel free to apply from wherever you're coming from. And you are welcome to use any of those templates that we provided, but again, they're not required. It's just something to use if you'd like it. And this pilot study mechanism is funded from NIH HEAL. But yeah, so that's kind of what I have on this website. If you have any questions, this is a great place to look up, but also we're available for any questions you might have.
And I'll offer to anybody that may be thinking of this, especially as we want to prioritize getting applications from non-researchers and researchers alike, meaning that RCOs and other peer organizations and other types of entities are highly encouraged to apply. But if you need any technical assistance or you want support or mentorship, the PRINS EAB and our scientific expertise individuals on the A.B.A.P are more than welcome to engage, as well as our core staff at the university. So if you have technical questions or if you want some support on how you're trying to structure your research or just get a sounding board, please reach out. And we're happy to help anytime between now to the end of October. So you can see that some of the other R24 grantees for some of this are on the call too. That's awesome. Yeah, happy to answer any questions that we can today, or we can set up some individual calls if you want to send out an email to Kirsten or to Daniela, who's our project manager on this, or to myself directly. I'll put my email in the chat.
Thank you so much, Kristen and Robert. Any questions from about this process or details of the application? You know.
I know Sierra had asked a good question in our pre-meeting, and just to highlight for those that may know, if your entity that's applying wants to forego indirect cost, otherwise known as F&A, many other titles, you're still allowed to apply for up to the maximum, which is that I think 55,000. So it's something to talk about with your institution, whether that's development or sponsored projects, whoever oversees grant applications. It is something that the amount doesn't go down if you do waive those or you decide to use the 10% de minimis, and we would highly encourage it since funding is limited to try to limit your F&A wherever you can.
Anything else, Kristen, you would like to add that would help with the application or?
No, I can't think of anything right now, but if when you get off the call and you have some questions lingering, please feel free to email us. There's no question too small. I know sometimes I need a moment after a meeting to process and think about what I have to ask, so please feel free to do that. We are around to help.
Is this like how long is the application?
It is going until the 31st.
No, I mean to say like in terms of the application itself, is that
There's
that
going to
like-
be a template that has all
Uh-huh.
of the information that you need. It is, there are a few pages, but the instructions are very helpful. I can't recall off the top of my head how long it is.
Okay.
Emmanuel has a great question in the chat. Oh, I see Robert answered it in the chat as well. But just, is there any opportunity for applicants from outside of America to apply?
That's a great question.
Robert, did you want to jump in with your response?
Happy to. Yeah, I was answering the second one. So at this time, given that it's a NIDA and NIH funding mechanism, it does need to be United States entity applicants that are authorized to do business in the United States and are formulated here. But we'll certainly keep an eye out and look for even additional opportunities in the future that are allowable outside of the United States. But that's a requirement coming from above us. Secondary question from Kristen around any prioritization for high-risk locations or populations. Not at this time. We're going to give prioritization to those projects that align with our priority research areas that came from our phase 1 and 2 study around topics from the community and the A.B.A.P that people want, where they want to see funding prioritized in terms of topical research areas. So prioritization and weighting will be focused on that. But again, you're allowed to apply for anything, but there won't be prioritization given towards specialty populations, but rather specialty topics.
And then a follow-up question. So the application entity does need to be in the United States, but that doesn't necessarily preclude them from collaborating with an organization outside of the United States, correct?
Not a lawyer, so I would have
Okay.
to defer on that. We can certainly look into it. I would urge and probably caution of proposing a project that is going to happen outside of the United States. Collaborators, yes, but in terms of the population and what you're proposing, it needs to be applicable to the United States for this funding mechanism for our project officers, et cetera. Would be a programmatic decision. In terms of a legal one, we'd have to get some further information. I can certainly follow up if you want to send that question or follow up over email. But again, I think for anybody potentially applying, we'd like to see projects and topics that are focused on applicability to United States populations at this time.
I also put into the chat box the Fogarty Center, which is an international, it's a NIH funding center that focuses on global health projects, on international projects. So that might be a great resource if you're outside of the United States as well.
Thank you. Emily?
Yeah, I was just curious. So it is a year-long project. If organizations had data that they were already maybe collecting, would that be an appropriate scope, or is it that they have to kind of propose a new thing to study? Like, is it flexible?
It's flexible. Secondary analysis, any other methodologies or approaches are certainly applicable as long as a case can be made. And we're not limiting it in terms of the overall approach, as long as the topic and the undertaking is applicable to peer recovery support services.
Great.
And when does the funding start? Like when are you announcing the awards? And
So that will be subject to some review of our internal university procedures. We do expect to make announcements before the end of the year after the closing of the application on October 31st, as our best estimate today.
okay.
And I would encourage everybody, as while we're on this topic, the other R24s, which one of my hub members, if you could grab the CORE's website link that has them all listed, they also do a variety of pilot funding under different names under their R24s as well. Not sure where they're at in their current cycles or if they're doing more. They have historically. So if this is something that intrigues you, they all have different focal points and different requirements, but they all have some tie back to recovery support services or recovery generally. In some ways. So it's certainly worth checking those out as well if pilot funding and this type of research is intriguing to you.
Thank you. It's great information. Does anybody have any additional questions for Dr. Eddy as well? At this point.
I have a question for Dr. Eddy. So you have now two systematic reviews of peer recovery support services under your belt. What would you say, just because you have such a depth of perspective on what's available in the literature right now in this area, what would you say is the biggest priority? What are the biggest unanswered questions surrounding peer recovery support services right now? Where would you really prioritize research?
I obviously we'll always take more data if we can get it. So even though I think there's like established efficacy for linkage to treatment and treatment engagement, I'd still like to see more data there. We really, I think, need to hammer the point home. You can never have too much data. And even though there's a pretty strong signal for substance use benefits and substance use outcomes, I think, we could stand up more research there. But I really, really want to see I really want to know more about how peer recovery support services help people longitudinally to accrue recovery capital, because I think that's really, really, where they're going to be making all the difference. I want to know more about how peer recovery support services are bridging people between levels of care, which is often where we lose people when they're transitioning between, like a medically managed withdrawal unit and residential treatment or residential treatment and outpatient care. And to better understand, because we think we're pretty sure peers, are, covering a lot of those gaps, but I'd like to see more data. And of course, like I always want to know, like for whom and under what conditions, are these, this class of services helpful or most helpful. Thanks.
Thank you. Lindsay?
Yeah, so I am fairly new into the research side of things, right? That was peer for most of my career. And I will say that one thing I've noticed is that very often, without the lack of inclusion of people who are in the field, right? A lot of the times the surveys that I read and like the, the data that comes out is not as peer based as I would like. So I like, and that means like having people who with that lived experience, right, and who have been in those roles and who are a part of the community to help create those types of surveys and all those questions, right, I think is so important.
Yeah, nothing about us without us. I think you're right, and it's absolutely critical. I think that I'm really an advocate to. I really respect like AA's tradition of anonymity, but I also think it's really important that those of us, I'm in long-term recovery, and I've been more open about that. recently, because I really think it's important that we show people in the community like these sort of that recovery is possible. That people with substance use disorder aren't bad people, and that in recovery people do recover and they go on to do like really great things. And actually, we published a paper recently from our national recovery study data set, which was a nationally representative study we did 2017, and we just sort of, ask people, are you in addiction? Do you think of yourself as being in recovery from a substance use problem? We surveyed about 2,000 people, and we actually showed that people go on to do amazing things in recovery, but it doesn't get talked about enough. And I also think it's really important, sort of in parallel to that, to your point, that people in recovery do have a seat at the table at every level, like in research, in academia, but in government, and community health centers. I think it's really important. And I think maybe some of us are there, but we just haven't been open, and we don't always know who's there and who's in recovery and who's not. So I would advocate for more openness if people are comfortable with that. And but I think still, that for a long time we've been told, I guess by people like me and in the ivory academic towers, like how things should be and what we should be studying and the kinds of questions we should ask and how we should ask them. And I do really do think we need to have more people in recovery at the table.
Also one more thing, sorry. The other part of that is, we keep on going back to this idea of lived experience, but I always like to talk about like living experience, right? We need people who use drugs also to be partaking and participating in these, in creating and these types of surveys and things, data like that, because people who are currently using drugs are the ones that are still in the thick of it, right?
Yeah, no, you're spot on. I'm 100% with you. 100% with you. And we need to be, those voices need to be included too. Absolutely.
I'm sorry, I don't know how to raise my hand on this thing. My name is Kelly Rowe. I'm the CEO of Second Chance Opportunities. We're located here in Albany, New York, and I'm not a researcher, but I am a person in recovery.
Mm.
So we run a recovery community center. We also provide employment and housing. And from 2018 to 2023, we did a study with the Rockefeller Institute of Government here in New York State. And it was a great study. It counted a lot of things. The problem is the researchers were not people who were familiar with substance use disorders. So we really missed an opportunity, and I'm hoping to work with, I forget the gentleman's name, of course, because I'm on a call with 60 people. The gentleman, the researcher who's in London. Anyway, everybody, anyway, so we collect data on everything. And I would love to hook up with an actual researcher. So we know, yes, David Best in the UK.
Yeah, I was wondering if it was David. Yeah.
Yes, David.
Yeah.
So the first study, like our housing has a 96% success rate, and our people, there's no length of stay minimum. So we have people that have been in our housing for 5-10 years.
Mm-hmm.
And what they're accomplishing when they're in our housing is the capital that we're now collecting. So we're not just saying, oh, yes, they go to meetings, but we're saying they repaired their credit, they bought a car, they got married, they had a baby, they went back to school, the real like meat on the bones. And where we fit in the continuum of care is as people are coming out of treatment, they connect with us. And so before they've even left their treatment facility, we're connecting them with a part-time job. And if they work out on the part-time job, they can have a full-time job, and then they can apply to our housing. And then they're in our housing for as long as they want to be. And their housing is less than 30% of their monthly income. Not everybody in our housing works for us, but we run a full-blown janitorial company and where we employ over 110 people, and they're all people in recovery. But because I'm not a scientist and we're doing this all on spreadsheets and Access, anybody familiar with Access, that spreadsheet that you can make really long? Like, we're collecting data on medications that people are being given in treatment and then out of treatment, and the effects that those different medications have on people, like gabapentin, really bad, but it's being prescribed in New York for anxiety, and it's off-label usage and whatever. But I would love to connect with somebody to kind of help us, do this. Like, we're a
Yeah.
petri dish of recovery on steroids. I mean, it's a great place for a researcher to come and really see what we're doing and how we're doing it.
Yeah, fantastic, Kelly. It's very, very hard to it's hard to do these kinds of self-studies if you don't know how to administer measures and collect and organize data. It seems like a fairly simple proposition, right? We'll just give people questionnaires and collect data, and but invariably when you drill down into it, it gets so much more complicated. So I'm glad you're connecting with David. He is the director of a research institute at Sheffield University or Leeds. I think he moved recently at Trinity. Trinity, right?
Trinity. Yeah.
Trinity, yeah. And I know they do some consultation work where they can actually, even from the UK, they're currently doing some consultation for a program at Mass General Hospital called Recovery Works, which is an employment program in one of our outpatient clinics, and they're actually helping them self-study. So there are ways to sort of collaborate. And David Best, would be a great organization. But the Recovery Research Institute, sometimes we support providers and providing institutions, organizations for this kind of support as well. So feel free to reach out.
Thank you so much. I wanted to bring up this one question from Lindsay here in the chat and see if anyone has any workaround or suggestions. It is difficult to have meaningful inclusion of people who use drugs when many of these grants require drug testing of grantee employees.
I'm assuming that you mean the Drug-Free Workplace Act, which SAMHSA, NIH grants, et cetera, all have in there. I would say while that is in there, this was brought up at a recent SAMHSA meeting I was at. The actual implementation of that is lackluster, but it is still a very real barrier, right? And I think though that language is in there, how that is operationalized at the employer level, they do have some options with that, but it is something that needs to be addressed. It's been a call put out to SAMHSA as well as federal legislators to look at what that means. And that resounding call was made by harm reductionists at that SAMHSA summit in Denver earlier this summer, which got met with we're looking into it. So not a whole lot of clarity from the feds, but it's a barrier. But I do think there is organizations out there, Drug Policy Alliance and others, that while they agree to those terms, don't operationalize it in the same way to provide some relative insulation for people who use drugs. And it doesn't apply to people that are applying as vendors or contractors on a research team, but it does for direct grantee staff. So there's a little bit of flexibility depending on how it's structured, none of which are great solutions, but it requires federal involvement and changes to that legislation in the Drug-Free Workplace Act, which is abysmal.
Thank you so much, Robert, for clarifying that. And with that, I'll request you to please provide a summary of today's session. Robert?
Sorry, I was typing. No, I was providing summaries, happy to do it. So Dr. Eddy reviewed another one of his systematic reviews in terms of the state of the field, what we know about peer recovery support services, and I think more interestingly had the discussion after the fact of where we're going and what our priority areas are, which I hope everybody was listening to, because all of those were great topics of conversation for the funding opportunity that Kirsten discussed as we look to give out 3 awards to community-based organizations, other researchers, postdocs, new existing partnerships, hopefully aligned with our priority research areas, which you can find on the website. That does close October 31st, and we hope to award by the end of the year, graciously supported by our R24 from NIDA.
Thank you so much. And thank you all again for joining today's session. A special thank you to Dr. Eddy for his wonderful presentation today and for answering all the questions patiently, and for Kristen for bringing this wonderful funding opportunity to all of us and sharing its details. Please do reach out to her if you have any further questions or you want to know more about the application process. And thank you all for joining today's ECHO session. As a reminder to earn CME credits, please text the CME code using attend and 1009-7863 to 844-502-1338 by midnight tonight. Please also complete a post-session survey using the link in the chat. If you would like to present a research study or a work in progress to this group, please do email the Bevel Texas team at cstat@utisca.edu. We look forward to seeing you at our next session on Wednesday, October 16th at 12 noon Central. Have a wonderful rest of your day. Bye-bye.